Treatment of hydrocephalus, shunt physiology and prevention of infection. Hydrocephalus. An excessive accumulation of CSF within the head due to a disturbance of formation, flow or absorption. If left untreated, the patient may develop increased intracranial pressure, ICP. Result may be brain damage and/or death. Compliance and the cranium. The brain and skull contain three primary components: brain tissue, blood, cerebrospinal fluid. A change in any one of these components results in adjustment to the other two, which is called compliance. Cerebral spinal fluid, CSF. CSF is produced mainly in the ventricular system by the choroid plexus and is present throughout the central nervous system. CSF has many functions: remove waste, carry nutrition, regulation of brain function, neurotransmitter, paracrine and endocrine effects, cushions the brain, CSF production and absorption. CSF is produced at a rate of 20 ml per hour and is normally absorbed at the same rate. The brain and spinal cord system contain approximately 150 ml of CSF, 25 ml in the ventricles. The entire CSF volume is turned over approximately 3 times per day. CSF is transferred from the subarachnoid space into the superior sagittal sinus, venous system, through small granulations called the arachnoid villi. Gray anatomy 20th ed. 2 forms of hydrocephalus. Communicating. Full communication of CSF between ventricles and the subarachnoid space. Non-communicating. CSF cannot flow out of the ventricles due to blockage or malformation. Compliance and hydrocephalus. As discussed, the skull is a fixed vault with limited volume to hold brain tissue, blood, and CSF. If too much CSF exists, the blood and brain tissue are compressed or squeezed out, resulting in a possible neurological deficit. Causes of hydrocephalus. Acquired hydrocephalus, secondary. Tumors and cysts. Inflammation, meningitis. Absorption blockages. Subarachnoid hemorrhage, SAH. Normal pressure hydrocephalus, NPH. Head injury. Aqueductal stenosis. Idiopathic hydrocephalus, primary. Inf. Causes of hydrocephalus. Foramen of Monro. Gliosis. Colloid cysts. Absorptive obstruction. Arachnoiditis, post-hemorrhagic, post-meningitic, venous thrombosis. Third ventricle. Chismogiomas, craniopharyngiomas, arachnoid cysts. Pineal region. Tumors. Fourth ventricle, medulloblastomas, ependymomas, astrocytomas, Dandy-Walker cysts. Cerebral aqueduct. Aqueductal stenosis. Aqueductal forking. Subependymal. Gliosis, periaqueductal gliomas. Basilar obstruction. Arachnoiditis. Chiari malformations, symptoms of hydrocephalus. Usually associated with high intracranial pressure, ICP. Headaches, nausea, vomiting, sleepiness, irritability, seizures, downward deviation of the eyes, blurred vision, failing mental function, other problems. In infants, expanded head or bulging fontanelles, sunset sign. Pediatric hydrocephalus. Pediatric etiologies. Intraventricular hemorrhage, IVH, occurs often in premature babies. Congenital hydrocephalus. Tumor. Adult hydrocephalus, adult etiologies. Normal pressure hydrocephalus, NPH. Subarachnoid hemorrhage, SAH. Post-trauma, aneurysm. Pseudotumor cerebri. Adult onset of congenital hydrocephalus. CT-MRI criteria of HCP. Hydrostatic hydrocephalus suggested when the size of both temporal horns is greater than 2 mm in width, Sylvian, interhemispheric fissures and cerebral sulci are not visible, or both temporal horn are more than 2 mm and the ratio FH/ID greater than 0.5. CT MRI criteria cont. Ballooning of frontal horns of lateral ventricles, Mickey Mouse ventricles, and third ventricle. Paraventricular low density on CT or paraventricular high intensity signal on T2W1 on MRI suggesting transependymal absorption or migration of CSF. CT MRI criteria cont. Used alone FH/ID less than 40%, normal. 40 to 50% borderline. Greater than 50%, HCP. Evans ratio of frontal horn to maximal biparietal diameter 30%. Sagittal MRI may show upward bowing of corpus callosum. Treating hydrocephalus. Medical management. Spinal tap. Surgical management. Medical treatment. Diuretic therapy tried in infants with bloody CSF to see if there is any resumption of normal CSF absorption. Acetazolamide and furosemide started simultaneously. To counteract acidosis, start alkylsultumec of K+/ml, Nona+. S.E. Electrolyte imbalance, lethargy, tachypnea, diarrhea, paresthesia. Spinal taps. HCP after intraventricular hemorrhage may be transient. Serial taps may temporize until reabsorption resumes, but LP can only be performed for communicating HCP. If reabsorption does not resume when protein is less than 100 mg/dl, then it is unlikely to start as before. Surgical treatment. Goal: optimum neurologic function and good cosmetic result, not normal-sized ventricles. Options: eliminating the cause of obstruction. Endoscopic methods. Shunting, endoscopic, third ventriculostomy. Indications: obstructive HCP. Shunt infection, removal of hardware. Patients with subdural hematomas, shunt removed before TV is performed. Slid ventricle syndrome. Contraindication: communicating HCP. Endoscopic, third ventriculostomy cont. Complications: hypothalamic injury, transient third and sixth nerve palsies, uncontrollable bleeding, cardiac arrest, traumatic basilar artery aneurysm, third ventriculostomy cont. Success rate overall equals 56%, ranges 60 to 94% for non-tumoral aqueductal stenosis. Success rate is lower in infants as they may have underdeveloped subarachnoid space. Lower success rate, if pre-existing pathology present like tumor, previous shunt, previous SAR, WBRT, adhesions. Endoscopic choroid plexus coagulation. First done by Danby-Open. Indications: communicating slowly progressing HCP in infants -64% cured. Choroid plexus papilloma/hyperplasia. Necrotizing enterocolitis. Intractable shunt failure. Contraindication: obstructive HCP. Endoscopic fenestration. Septostomy, for ULHCP. Multiloculated HCP. Aqueductoplasty or aqueductal stenting. Cysts with secondary HCP: arachnoid cyst, cysticercal cysts, 3/4 ventricle. Colloid cyst of third ventricle. Pineal region tumors, ETV plus biopsy. Types of shunts: VP shunt, VA shunt. Torkelison shunt, ventricles to cisternal space. Miscellaneous ventriculopleural, gallbladder, ureter or bladder. LP shunt. Cyst or subdural shunt. Shunting surgical goal: shunt considerations. Redirect CSF to another area of the body to normalize ICP. Shunt considerations. Choose the correct operating pressure, fixed pressure valve. Avoid catheter obstruction. Avoid shunt infection. Avoid other issues. Blood, high protein in CSF. Catheter disconnection. Surgical procedure. The surgical procedure to place a shunt is relatively short and uncomplicated. Incision in the scalp. Small burr hole on the skull, 6 to 9 mm. Insertion of the ventricular catheter. Incision in the peritoneal cavity. Tunneling under the skin. Closure. VA shunt repeated lengthening required in a child. High risk of infection and septicemia. Possible retrograde blood flow into valves. Shunt embolus. Vascular complications, thrombophlebitis, pulmonary emboli, PHT. LP shunt. Do not use in child. Laminectomy causes scoliosis, risk of progressive scoliosis. Overshunting may cause 3rd and 6th CN palsies. Difficult access to proximal catheter for revision. Lumbar root irritation. Leakage of CSF around catheter. Pressure regulation is difficult. Arachnoiditis. Torculitis in shunt shunts ventricles to cisternal space. Rarely used. Effective only in acquired obstructive HCP, as children with Cong HCP frequently do not develop normal subarachnoid CSF pathways. Ventriculopleural shunt. Viable alternative if peritoneum is not available. Risk of hydrothorax requiring relocation of distal catheter. Recommended only for greater than 7 years of age. Disadvantages/complications of various shunts. Those that may occur with any shunt. Obstruction M.C, proximal catheter valve/distal catheter 12 to 34%. Disconnection. Infection. Hardware erosion through skin. Seizures 5.5% in eye ear, 1.1%/ear after 3 ear. Higher and frontal catheter. Conduit for extraneural mets. Silicone allergy. VP shunt complications. Inguinal hernia if inserted when processus vaginalis is patent. Requires long catheter to compensate for child growth. Peritoneal end obstruction more with distal slit valves. Biperitoneal pseudocyst. Peritoneal adhesions may decrease absorptive surface. Catheter malpositioning. VP shunt complications. Kint. Peritonitis. Hydrocell. CSF ascites. Tip migration into scrotum. Viscous perforation, through diaphragm. Intestinal obstruction. Volvulus. Intestinal strangulation shunt removed forcibly. Overshunting. Shunt complications. Infections. Incidence -1.5 to 38%. International Society of Pediatric Neurosurgeons Cooperative Study 1994 6.5%. Mortality, morbidity, costs. Time to infection -92%. Infections occur within 3 months. Shunt complications. Infections. Kint. Risk factors. Age, most important. Different skin flora, less immunity and dig. Reason for shunt placement. Type of shunt. Educational level of surgeon. Presence of spinal dysraphism. 50% children with MMC who were shunted within 1 week develop shunt infection. Shunt infections. Kint. Presentation. Headache, lethargy, nausea and vomiting. Infant's irritability, severe apnea and bradycardia. Fever, gait disturbance, seizures, visual disturbances, upgaze palsy, papilledema, abdominal pain, swelling. E. coli, severe abdominal pain and septicemia, staph indolent, erythema along tract. Shunt infections, evaluation and diagnosis. History and examination, DD especially in children. URI, gastroenteritis, UT, appendicitis. Imaging. X-ray shows disconnection of the system. USG-cranium, ependymal enhancement, abdomen. CT scan. Shunt tap CSF and manometry. Shunt tap. Indication. Diagnosing infection/cytology/remove blood/check function/inject medication. 2. Steps. Insert a 25-gauge butterfly cannula and look for flow. Measure pressure. Measure pressure with distal occlude pressed. If no spontaneous flow, try to aspirate CSF with a syringe. Send CSF sample. Connect with manometer. Repeat measurement after injecting 3 to 5 milliliters of saline. Shunt infections prevention. Sterile surgical technique. Haynes and Walters have found 50% reduction in infections with use of prophylactic antibiotics. Antibiotic-impregnated shunt tubing. Use of antibiotics before dental procedures, one-piece system, biannual screening, hypothermia during surgery. Shunt infections organisms. Shunt infections treatment. Medical. Surgical. Replacement. Externalize. Removal. 4 plus IT plus vent. 4 abs. Treatment outcomes. Frame and McLaurin-Jane neurosurgery. Shunt complications over shunting. 10 to 12%, VP shunt greater than VA shunt siphoning. Slit ventricle. Subdural hematoma. Craniosynostosis. Aqueductal stenosis/occlusion. Intracranial hypotension. Undershunting shunt malfunction rate 17% in IEA. Cause blockage, choroid plexus/proteinaceous material/blood, disconnection. Symptoms H/A and V, diplopia, lethargy, ataxia, infants, seizures. Signs upward gaze palsy, 6th CN palsy, field cut, papilledema. Shunt complications, continued. Disconnection. A part of the system becomes disconnected. The connections between catheters, valves or accessories are damaged, sometimes due to growth of the patient. Bowel perforation. The distal/peritoneal catheter perforates the bowel. Must be revised. Physiology of shunt devices. History. Hippocrates probably did first ventricular puncture. Nelson and Spitz did the first ventriculojugular shunt. Hydrodynamics. Flow equals PR. R equals A10L/R4. P equals IVP plus PGHOPVDCP. Shunt physiology. Siphoning. Difference in the height of ventricular catheter and that of the distal catheter causes pressure differential equal to PGH. Hysteresis. It occurs dt. Slight change in the mechanical properties of the valves, depending on whether they are opening or closing. Seen with slit and mitre valves. Shunt systems. Shunt systems come in a variety of configurations and models, but they have similar functional components. Valve mechanisms, flow or differential. Fixed, programmable, or variable settings. Catheters. Ventricular, proximal. Peritoneal/atria, distal. Accessories. Reservoirs, siphon devices. Connectors, filters, pumping chambers. Shunt components. Catheters. Ventricular catheters. Placed in the ventricles to deliver CSF to the valve or distal catheter. A series of holes in the ventricular catheter allows CSF to enter the shunt system. Types of ventricular catheters. Shunt components, catheters. Distal catheters. The distal tubing is made of silicone and has got slit valves near the distal end with close-ended tube or open-ended. Valves function when open end gets blocked. Shunt components, valves. Mechanism which helps regulate the ICP by redirecting enough CSF distally. The valve must provide the optimal balance of CSF diversion, not underdrain or overdrain the ventricles. The valves are one-way and have operating pressure ranges or opening pressure settings. Valve basics. Proximal valves. Distal valves. Valves placed close to the ventricles. Distal valves. Valves placed in the peritoneum, away from the ventricles. Shunt valves. Differential pressure valves. Slit valves, distal or proximal. Mitre valves. Hysteresis occurs. Diaphragm valves, most common. Ball and cone valves. Defined by their opening pressure. Flow-regulated valves. Designed to increase the hydrodynamic resistance as the pressure gradient increases. Keep flow rate constant. Less likely to be associated with siphoning, but due to small orifice have higher chances of getting obstructed. E.g. Orbis sigma valve. Gravity-actuated valves. Gravity-actuated valves attempt to prohibit or reduce siphoning by increasing opening pressure with assistance of gravity when patient sits up. E.g. Cordis horizontal vertical valve for use with LP shunt, anti-siphon devices. This device is typically placed under the scalp, has a small diaphragm that reduces the rate of CSF flow when pressure inside the shunt falls below atmospheric pressure. Wire programmable valve. Flow equals P, R. P equals I.C.P, op plus HP, pp. 30 mmH2O. 200 mmH2O. Patient dependent, age, physiology. Time dependent, activity, growth, adaptation. Adjustable valves. Valve mechanism allows you to change operating pressure non-invasively. Codman valve. Codman programmable valve. 18 pressure settings, valve components: ball and seat, synthetic ruby baseplate, titanium. Cam, polyether sulfone. Stator, nickel alloy. Magnets, samarium cobalt, SMCO. Housing, silicone. Spring, stainless steel. External influences investigated during device development. Vibration and shock studies. Normal activity levels. RF field studies. Household appliances, cell phones, airport security gates. Strong magnetic field studies. MRI units. Strong household magnets, external magnetic fields. Magnetic field threshold for deprogramming. Greater than 80 Gauss, 1 step, optimal conditions. Examples. Headphone 50 Gauss at the surface. Household appliances less than 10 Gauss. Magnetic therapy pillow greater than 430 Gauss. 1.5 Tesla MRI 15,000 Gauss. CHBV programmer 325 Gauss. Equals greater than unlikely the valve will be affected by everyday sources. Warnings, precautions. Valve is supplied without a preset pressure and must be programmed prior to implantation. Aseptic surgical technique. Don't flush, fill or pump valve with lint-containing fluid. Take care to prevent shunt from touching surface. Don't tie switches tightly. Don't move the transmitter during programming. X-ray verification. Shoot film perpendicular to the plane of the valve. Shoot film in relation to valve and not patient anatomy. Non-implanted site of patient's head should rest on plate. Any angle other than 90 degrees may lead to misinterpretation of pressure setting. MRI study safe for use, MRI conditional. No movement of valve in tissue pocket. No selective heating. No effect on valve performance. Must reprogram after each MRI. MRI will change the pressure setting. Post-op programming. New pressure setting determined by patient clinical symptoms. Locating valve mechanism, palpate hard plastic casing. Mark position of valve mechanism with finger or surgical market. Transmitter head placed directly over the cam of valve mechanism. Verify setting with VPV, X-ray or fluoro, X-ray verification. As illustrated below, there is a direct correlation between the position of the programming unit control panel pressure selector buttons and the position of the pressure indication on the valves as seen when X-rayed. When the valve is programmed to 70, 120, or 170, the pressure indicator aligns with the X in the center of the valve. X-rayed valve information. The white marker on the valve, 1, indicates the right-hand side of the valve. The marker will not be seen on the X-ray if it is positioned on a 30 degrees angle or more. The valve cannot be programmed if the angle is 45 degrees or more. The pressure indicator on the white ring, 2, denotes the chosen pressure. Non-X-ray verification. Clinical need. Minimize patient exposure to X-rays. Clinician performing the reprogramming. Improve ease of use. Methods investigated. Magnetic verification of valve setting. Acoustic verification of valve setting. Infrared laser. Ultrasound. We have heard from our CHBV users that it would be an improvement to have a method to verify the valve setting without having to take an X-ray. I would like to get some feedback from you. What compels you to take an X-ray with our valve? You told me I had to. I need to know where the setting is. We know that the other adjustable valve uses magnetic designs and we looked at that, but avoided it due to unwanted outside magnetic influences. We conducted extensive customer research and we decided to utilize acoustic technology, which makes all implanted valves compatible with this technology. Antibiotic impregnated shunts. Bacteria in shunting. Most common bacteria in shunt infections: S. epidermidis, S. aureus, coriforms, streptococci, enterococci. Account for approximately 77% of shunt infections. Antibiotic impregnated shunts. Effectivity. It is not intended to be effective against all causative organisms for shunt infections. It is effective against the bugs that are susceptible to rifampicin and clindamycin. Rifampicin and clindamycin are effective against most strains of bacteria that cause shunt infections. Antibiotic impregnated shunts. A shunt infection occurs when a pathogen attaches itself in or on the shunt. Majority of bacterial contamination is introduced at time of surgery. Infection becomes clinically evident in 3 to 4 weeks post-op. Shunt infections can be both internal or external to the shunt. Internal or external. Internal majority S. epidermidis or coriforms. Minority. Wound infections complicated by foreign body. S. aureus. Antibiotic impregnated shunt colonization process. Staph. Bacteria adhere to the silicone. The bacteria produce an extracellular slime. This slime adheres to the inner lumen surface of silicone catheters. Internal shunt infection. The organisms start to multiply, and they produce extracellular slime. This can, in time, completely block the shunt. Antibiotic impregnated shunt. Ventricular and distal silicone catheters, impregnated with 2 antibiotics, rifampicin and clindamycin. And they are orange. How are they made? CHCl3. Matrix. Contracts. Trapping. Drugs. Inside. Normal. Silicone. Molecule. Matrix. In chloroform. The matrix expands. Squeezed. In under. Pressure. The antibiotics. Fill the gaps. How do they work? Bacteria from the skin. CSF. CSF. Bacteria from the skin, introduced during implantation, are carried by the CSF and attach themselves to the catheter surface. CSF. Laboratory studies have shown that the protective. How do they work? CSF. Laboratory studies have shown that the protective effect is active for at least 28 days protection. Most shunt infections occur within the first month, having been introduced during implantation. CSF. Positive diffusion gradient. How do they work? CSF. Due to the concentration difference between the catheter and the external environment, there is a positive diffusion gradient, which causes the drugs to slowly diffuse out of the silicone. CSF. The concentration of drugs at the surface of the catheter is high enough to inhibit colonization. CSF. How do they work? CSF. The concentration of drugs at the surface of the catheter is high enough to inhibit colonization. CSF. Precautions pre-implant technique. Surgeons should not pre-soak Bactiseal in saline or antibiotic solutions prior to implantation because the diffusion process will be activated. Precautions: packaging it is sterilized by autoclave. It cannot be sterilized in the same way as valves. For this reason it cannot be supplied packed with the valve or unitized. It must be stored in a temperature-controlled environment not to exceed 80 degrees Fahrenheit, 27 degrees Celsius.